I am Dr. Sridhar Silva, consultant pediatrician and APLS instructor. I am going to speak to you on how to apply shockable and non-shockable protocols in pediatrics. I am following the APLS guidelines of Australia and New Zealand. If you are following any other course, please use the instructions given in that course. When a patient collapses or arrested in a hospital setting, always look for the environment or the situation in which the patient is going to be managed. This is known as situational awareness. This can happen in the emergency unit, general ward, or the radiology department. Check whether the patient is responding or not and call for assistance. You may activate rapid response team or medical emergency team. When you call for assistance, you need to ask for the equipment in the crash cart and a defibrillator. In the pre-hospital setting, you need to ask for an automated external defibrillator. But in hospital setting, you need to ask for a defibrillator. Other items you will be looking for are airways, self-inflating bags, IV cannulas, IV fluids, emergency drugs, syringes, and laryngoscopes with endotracheal tubes. After danger, responsiveness, and send for help, try basic airway opening maneuvers like head tilt and chin lift. If you are a left-hander, keep your left hand on the head and the fingers of the right hand on the chin. You have to be careful not to put pressure on the soft tissues of the floor of the mouth. Tilt the head to a neutral position under one ear, sniffing position over one ear. In the neutral position, keep the earlobes parallel to the floor, and for the sniffing position, keep the neck slightly extended and ears towards the shoulder. Having opened the airway with head tilt and chin lift, keep your head and face over the patient's face to listen and feel for the breath and to watch for the rise and fall of the chest wall movements. If airway is not open with head tilt and chin lift, you may try jaw thrust. Keep your middle finger under the angle of the jaw and raise the jaw 90 degrees up. It is important to maintain either neutral position under one ear, sniffing position above one ear while performing this maneuver without tilt in the head. The jaw thrust is specially indicated in trauma patients where the head tilt and chin lift is contraindicated. Again, look, listen, and feel for breath. Now you find the patient is not breathing or apneic. You need to start on ventilation breaths with the correct size of self-inflating bag. There are three sizes of bags available: 250 ml, 450 ml, and 1500 ml. It is important to choose the correct size and the shape of the face mask that fits onto the patient's face, and try to fix that into self-inflating bag. Check whether the self-inflating bag and the pop-off valve is working. When the self-inflating bag is applied onto the face, it should cover the nose and mouth and have an adequate sealing of the face mask with C&E technique, and make sure there is no air leaking when inflated. This is called C&E technique. Start bag and valve ventilation and watch for the chest rise. Chest rise is an important sign indicating the airway is patent and the air is reaching the alveoli. Check for the pulse in children for 10 seconds. You need to feel carotid pulse above one ear and brachial pulse under one ear. If there is no pulse for more than 10 seconds, start on chest compressions. If pulse is less than 60 per minute, look for signs of life. Absent signs of life are absent breathing or gasping breathing or irregular breathing. The patient's movement may be absent, and absent coughing and absent gag reflex. The skin may look pale and mottled. In summary, if no pulse is felt or pulse is less than 60 per minute with poor signs of life, you need to start on chest compressions. Effective basic life support is important. Good quality cardiopulmonary resuscitation is important. One assistant should hold the mask of the self-inflating bag with the double-handed jaw thrust to prevent aerosol generation. Other assistants should continue chest compressions and effective ventilation with bag valve mask ventilation, the ratio being 15 chest compressions and 2 breaths. As the team leader, you need to attach ECG leads to the chest and switch on the monitor, which is number 1 on the defibrillator. The rhythm appears on the monitor as a flat line. Make sure chest leads are not disconnected and always try to get rhythm in the lead 2 and increase the gain. Pause the chest compressions for a second. Identify the rhythm, flat line, which is asystole, and restart the cardiopulmonary resuscitation. This is non-shockable rhythm protocol. So we need to follow the asystole protocol in this instance. After confirming asystole, recommenced on the cardiopulmonary resuscitation. Try to get IV access or the intraosseous access and take blood for the blood sugar and serum electrolytes. Prepare adrenaline from 1 in 10,000 vials to 1 in 1,000 concentration and label it. Take 1 ml of adrenaline and mix with 9 ml of normal saline in a 20 ml syringe. The dose is 0.01 ml per kg and 5 to 10 ml of normal saline flush. At this moment, the 2 minutes is over and it's time to do the next rhythm check before giving adrenaline. At the end of 2 minutes, pause the chest compressions. Check the rhythm again. Asystole confirm and reconfirm that the leads are not disconnected. After confirming asystole, start on chest compressions and back wall mask ventilation 15:2 ratio. Administer adrenaline 1 in 10,000, 0.1 ml per kg and flush and continue good quality CPR for another 2 minutes. While good quality CPR is going on, look for 4 H's and 4 T's. Check for hypoxia. Check whether the oxygen is connected to the self-inflating bag. Check for skin color to see patient is hypovolemic and decide on the fluid bolus. Feel the skin for hypothermia and make sure the temperature is maintained. Correct anything else as suggested by the history of the child's illness or injury. At the end of 4 minutes, again pause the chest compressions and for rhythm check. You notice a slow sinus rhythm. But when you check pulse, there's no pulse. So pulseless electrical activity or PEA is confirmed. Restart the chest compressions and back wall mask ventilation 15:2 ratio after confirming pulseless electrical activity. Administer intravenous or intraosseous adrenaline 1 in 10,000, 0.01 ml per kg and flush and continue good quality CPR for another 2 minutes. While good quality CPR is going on, look for again 4 H's and 4 T's. Check for hypoxia and correct it. Make sure oxygen is connected and oral airway is inserted. Otherwise, you may have to consider laryngeal mask airway or even intubation. Check for the skin color and the skin temperature. If peripheral cannula is not working, go for intraosseous access and correct hypovolemia with the fluid bolus. Feel for the temperature and cover the patient with a warm blanket. Also listen to the chest, both sides for tension pneumothorax and listen for heart sounds at the apex for muffled heart sounds. Pneumothorax and the cardiac tamponade could be picked up with ultrasound scan examination in the emergency room. After 2 minutes of good quality cardiopulmonary resuscitation, the management of asystole and pulse electrical activity, check for the return of circulation. Check for ECG for sinus rhythm on the monitor and feel for the central pulse. If central pulse is present, then stop the chest compressions. Check the pulse rate and the pulse volume and decide on a fluid bolus. Check for breathing. If no breathing, start on back wall mask ventilation. If patient is breathing, provide oxygen, ideally through the non-breathing mask, or if not available, by simple face mask. Reassess airway, breathing, circulation, disability, and dispose the patient to the intensive care unit. In asystole and pulse electrical activity, adrenaline should be given every other cycle. We'll talk about the defibrillation using paddles now. It is important to locate the defibrillator in the unit, and also it is important how to operate defibrillator in the emergency situations. When somebody collapses in front of you, the chances of having ventricular fibrillation is 75%. with every 1 minute after the collapse, the chances of reverting ventricular fibrillation to sinus rhythm goes down by 10%. This means there's no point giving CPR after 10 minutes of cardiorespiratory arrest. In patients with cardiorespiratory arrest, there is no breathing and no pulse. They are apneic and pulseless. Check for breathing by looking, listening, and feeling for the breath, and check for the central pulse either in the carotid artery or the femoral artery for 10 seconds. Effective basic life support is important. Good quality cardiopulmonary resuscitation is important. 15 compressions and 2 breaths. Assistants should hold the mask of the self-inflating bag with a double-handed jaw thrust to prevent aerosol generation. Circulation assistant should continue chest compressions and effective ventilation with the bag wall mask ventilation. As the leader, you need to attach the ECG leads onto the chest and switch on the monitor, which is number 1. The rhythm appears on the monitor as ventricular fibrillation. Make sure the leads are not disconnected. Always get the rhythm in the lead 2 and increase the gain. Pause the chest compressions for a second. Identify ventricular fibrillation and restart on cardiopulmonary resuscitation. Start compressions, chest compressions, and bag wall mask ventilation 15 to 2 after confirming ventricular fibrillation, and prepare for a shock. Now we will go through how we are going to apply shockable protocol to this patient. Take the paddles out with the correct hands. For pediatric patients, there are pediatric paddles fixed into the adult paddles. Place the right-handed paddle onto the apex and the left-handed paddle just below the left clavicle. Switch off the oxygen flow and remove the bag wall mask ventilation or the self-inflating bag. Shout for stand clear, head clear, middle clear, bottom clear, and arm clear, and wait until charging is completed on the monitor. Once charged, do another safety check. Head clear, middle clear, bottom clear, arm clear, and discharge the energy. Return the paddle safely to the defibrillator. Recommence good quality CPR. After discharging a shock for the ventricular fibrillation, you need to recommence cardiopulmonary resuscitation as is said. Try to get an IV access or intraosseous access and take the blood for blood sugar and electrolytes. Prepare adrenaline 1 in 10,000 concentration from 1 in 1,000 vials and label. Take 1 ml of adrenaline and mix with 9 ml of normal saline in a 20 ml syringe. The dose is 0.1 ml per kg with a flush of 5 to 10 ml of normal saline. At this moment, the first 2 minutes is over. You need to check the rhythm again before giving adrenaline. The rhythm appears on the monitor as ventricular fibrillation. Always get the rhythm in the lead 2 and increase the gain. Pause the chest compressions for a second. Identify the ventricular fibrillation and check the pulse as well. And you need to start chest compressions immediately. While continuing chest compressions, take the paddles out with the correct hands. For pediatric patients, there are pediatric paddles fixed into the adult paddles. Place the right-handed paddle over the apex and the left-handed paddles below the clavicle. And switch off the oxygen flow and remove the self-inflating bag. Shout for stand clear, head clear, middle clear, bottom clear, and clear. And wait until charging is completed on the monitor. Once charged, do another safety check and discharge the energy. Please return safe paddles safely to the defibrillator. Recommence the good quality CPR immediately. So while continuing chest compressions and bag wall mask ventilation 15 to 2 after confirming, administer intraosseous or intravenous adrenaline 1 in 10,000, 0.1 ml per kg with a flush of 5 to 10 ml of normal saline, and continue good quality CPR for 2 minutes. While good quality CPR is going on, look for 4Hs and 4Ts. Check for hypoxia and correct it. Make sure oxygen is connected, oral airway is inserted, otherwise consider laryngeal mask, airway or intubation. Check for skin color and skin temperature. If peripheral cannula is not working, go for intraosseous access and correct hypolemia with the fluid borders. Feel for the temperature and cover the patient with the warm blankets. Check the ECG or serum electrolytes, serum potassium for evidence of hyperkalemia. Also, listen to the chest on both sides to check for tension pneumothorax and listen for heart sounds to check muffled heart sounds. Pneumothorax and the cardiac tamponade could be picked up with ultrasound scan examination in the emergency room. Always look for history of toxins and thromboembolism. After 2 minutes of good quality CPR and the management of ventricular fibrillation, check for return of circulation. Check for the ECG for sinus rhythm on the monitor and feel for the central pulse. If present, then stop the chest compressions. Check for pulse rate and pulse volume and decide on a fluid bolus. Check for breathing. If no breathing, start on bag wall mask ventilation. If patient is breathing, provide oxygen through the non-breathing mask, or if not available, by simple face mask. Reassess on airway, breathing, circulation, and disability, and then dispose the patient to the intensive care unit. Chest compression should be uninterrupted. Push hard, push fast. There should be clear instruction for the chest compressions to be interrupted. Continuing chest compressions will improve the outcome. Chest compression should be interrupted during rhythm check and during charging and discharging shock. When using drugs, the adrenaline is after the second shock. Amiodarone is after the third shock. Thereafter, adrenaline should be given every other cycle. With pediatric life support, with COVID-19 consideration, certain strategies are adopted to prevent the aerosol generation. Full personal protective equipment should be available in high-risk areas. Aerosol generation procedure should be minimized. Personal protective equipment should be worn when inserting oropharyngeal airway, laryngeal mask airway, external chest compressions, bag wall mask ventilation, or intubation. When intubating, use the cuff tubes rather than non-cuff tubes. One person should hold the mask with a double-handed jaw thrust tightly to prevent aerosol generation. Fix viral filters between the airway circuits and the face mask. Oxygen flow should be made zero before disconnecting bag wall mask ventilation from the intratracheal tube. When a person collapses, early recognition of cardiopulmonary arrest is important and then call for help. The bystander should start on chest compressions and call for 1990 through the app. Early defibrillation using automated external defibrillator in out-of-hospital cardiac arrest and the use of the defibrillator in hospital setup is important. Post-resuscitation care should be given at the proper place. These are the adults as well as pediatric basic life support and the ALS protocol. It's important to note that the DRS and ABCD approach is same on both protocols, but there are few differences. In adults, the head tilt, chin lift, and the jaw thrust with the check-in of the carotid pulse should be done at the same time. This is called triple menu. There are few differences between adult and pediatric life support. In adults, no rescue breaths are needed. Start with chest compressions. And the ratio, the compression ventilation breath is 30 to 2. This is the adult pediatric life support protocol. Post-cardiac arrest strategies include re-evaluate the vital signs ABCD, 12-lead DCG, pulse oximetry to check oxygen saturation, blood pressure, capnography, check urine output, treat precipitating cause, and re-evaluate oxygenation and ventilation, and temperature control and consider cooling. In cardiac arrest, the family members should be offered the opportunity to be present during the resuscitation of the child. However, if the presence of parents is impeding the progress of resuscitation, they should be sensitively asked to leave. In summary, DRS is the initial approach. Airway opening maneuver, check for normal breathing, 2 breaths, check for pulse, CPR, assess the rhythm, and use the protocol, shockable protocol or non-shockable protocol and post-resuscitation care. Thank you.